So again, remember these are guidelines, and so this is actually not really our specialty per se. Most of the pregnancy patients tend to stay at primary care doctors, and they tend to stay with obstetricians and stuff. So we, personally myself, I see mostly type 1 diabetics that are on insulin and insulin pumps and kind of crazy. So this is just moving into gestational diabetes management. Go ahead, next slide. Can I get rid of that? Hold on, I gotta try to get rid of something. There we go. Ooh.
Is that little thing down there, the blue one on the bar? Yeah.
Okay. So treating or testing for overt diabetes and pregnancy is to be completed within the first visit. Most of the time, this is also, again, done at an obstetrician's office. We're looking for fasting blood sugars. We also consider an A1C or a random glucose level to check for overt diabetes. And that's be confirmed by 2 testings. We don't just use one. So you'll actually pick, if you did an A1C, then you want to do a random or you want to choose a fasting. And then we move into testing for gestational diabetes, and this is done a little bit later in the pregnancy. Again, this is something that's happening at the obstetrician's office. It's not through primary care or even us. So you're going to test somewhere between the 24 and 28 weeks of pregnancy, and this is done when there's not overt diabetes already existing prior to pregnancy, or if you've also had the history of gestational diabetes in the past, and they do that with the oral glucose tolerance testing. So, and then 1 or more abnormal values are needed to establish also gestational diabetes. Next slide. Management of elevated blood glucose levels during pregnancy is a lot of diet, so it doesn't change anything that we already are preaching to our diabetics in general, is watching for low carbs, getting them to medical nutrition therapy, and instilling exercise. Again, exercise isn't great to start once you're already pregnant. You're kind of hoping they're starting that before, and at this point trying to encourage them to continue with it and not backing off on it just because they're pregnant. And then if you remember from last week, Renee already went over some of the pharmacological things of metformin and glucotrol. So after pregnancy, we should see a resolve of gestational diabetes at this point. So we end up doing postpartum testing. And again, it's most of the time isn't us, but if they lose some type of, follow-up with their obstetrician, then this would be something that you guys as primary care providers would need to be able to do. And it's the oral glucose tolerance test about 6 to 12 weeks postpartum. If it's normal, you repeat periodically with future pregnancies. You don't forget about it with the next pregnancies or anything like that. Child's birth weight, child's birth weight, and if the mother had gestational diabetes, they should be part of their permanent record for the child, because that's increasing their risk later on in life from being a large baby and mom having gestational diabetes. You can pretty much, I shouldn't say bank on it, but I feel like in our clinic, and again, we see the worst of the worst, it seems like a lot of our diabetics will say, yep, I had gestational diabetes during my pregnancy, and it's 10 years later, 15 years later. So they need to continue with lifestyle changes just to prevent that from happening in the future, because the likelihood of it happening is great. And then after pregnancy, I already said this, that you would actually decrease your medications after delivery if they were just gestational diabetic, but not if they have overt diabetes. Next slide. Glucose monitoring and glycemic targets. Again, it's something that if they're coming in during their pregnancy that you would be looking at, but most of the time the obstetrician is also monitoring this with you, and if you're sending them to us, we obviously are. So go ahead, next slide. We're trying to make our targets a lot more strict, I think is the biggest thing, in either gestational or overt diabetes, and fasting should be less than should be equal to 90 without any hypoglycemia. This says us taking care of type 1s. Seems like sometimes it can be impossible to get that to happen, but you want them somewhere between 60 and 90 for fasting. It also talks about the preprandial, less than or equal to 95. I don't overly promote the 1 hour postprandial numbers, but they give it to us there as 140. I tend to always use the 2 hour postprandials of being less than 120. That's hard. They are pregnant and want to eat, and so it's a difficult number, but I utilize that a lot with them, type 1 or type 2. And then our A1C is to be 6.5. They have in there 7. It just depends on which guidelines you're utilizing, but 6.5 is kind of our target. CGMs, they're a blessing, and if you can get them to at least do it during their pregnancy and kind of take up the extra cost, they'll probably be happier. They'll do those 2 hour postprandial checks for you, and it'll keep them much better on target. When you use the CGMs, make sure they're checking for their blood sugar when they're less than 65, so they know that it's accurate. And on a pregnant woman, I'd say greater than 180, 200, they should be checking with the blood glucose again. Next. Hold on, I keep getting something popping up on my screen. Nutritional therapy and weight gain targets for women with overt or gestational diabetes. This is where we're talking to them a lot about nutrition. The rules don't really change, they're just more strict on where the glucose targets are. Next slide. So all patients should undergo medical nutrition therapy. It's very hard. They're busy, they're pregnant, they have other kids, but you need to kind of push pretty hard for them to do it. Carbohydrate intake, 30 to 45% of total daily calories, and distributing into small, moderate-sized meals and 4 snacks a day. It's a lot of information, but some people like to know exactly what should I do, and that's where guidelines say. But as you're pregnant, you just also have to encourage they need to eat for baby and eat for themselves, but it doesn't have to be carbohydrate, which is going to raise their sugars. In the obese, reduce intake by 1/3 compared to what they usually intake before pregnancy, while maintaining 600 to 800 calories a day. We talked a little bit about folic acid. Again, that's through the obstetrician most likely, but you want to just make sure that they're on it and reducing it after delivery and completion of breastfeeding. Next slide. So the agents, this is the insulin and non-insulin therapy. We actually touched on this last week as well. Next slide. So Detromere for long-acting insulin in those patients whose NPH in appropriate doses have previously resulted in, or in whom NPH may result in problematic hypoglycemia. So basically, we have drugs that are approved and not approved, but we tend to use more. So, they can actually stay on Lantus if they were on it prior to pregnancy and they were doing well on it. We actually don't have to change it, and you can kind of document that. But sometimes obstetricians just automatically start pulling things away from them and end up putting them on the NPHs and your Detromere. So those successfully, that's what they're using glargine before pregnancy may continue, and that's the statement that I just actually talked to you about. Rapid-acting insulin, Lispro and Aspart are used in preference to regular insulin. Lispro and Aspart, you should be telling them to be dosing about 15 minutes before they eat. It's the onset of action to make sure that whenever the food's there, that it's actually meeting and it doesn't cause such spikes on them. So getting people to dose prior to eating is something we try to enforce and encourage immensely, no matter what, type 1 overt or gestational. Recommend ongoing use of continuous insulin infusions when initiated prior to pregnancy. We have a few that have been initiated at the onset of pregnancy, not the best time. Knowing that through pregnancy that you'll need more and more insulin, so in the first 2 trimesters, their doses will go up and up and up and up, and you just need to keep, trying to reach those targets. They're not doing anything wrong. It's just the nature of being pregnant and the resistance that occurs. Do not initiate continuous subcutaneous infusions unless strategies have first been tried and proven unsuccessful. And that's pretty much what everyone does. We wouldn't start that. Next slide. Next slide. Non-insulin agents, we talked about that. They're both not FDA approved, but we know that we can use them. Glyburide is an alternative to insulin for those that can't achieve goals 1 week after medical nutrition therapy and exercise. So basically starting all the lifestyle stuff first, and those that are diagnosed prior to 25 weeks of gestation and their fasting glucoses are greater than 110, insulin is preferred. And metformin can be used for those who do not have satisfactory glycemics despite, again, medical nutrition therapy or refuse insulin or glyburide, and are not in the first trimester. It does cross through the placenta and increase rates of premature labor in women with gestational diabetes. So those are the bad things that we hear about it, but normally we see pretty good results. Next slide. Labor, delivery, lactation, postpartum care. Again, after delivery with gestational diabetes, we talk about the decreasing resistance and stopping the medications. And next slide, we'll go through some of the postpartum issues. Target glucose postpartum is 72 to 126 while you're delivering. This one really, these are again guidelines so that you guys can reference them, but it's not something that you're going to be utilizing in your practice because it's obviously during labor. Recommendations for breastfeeding is to reduce the infant's childhood obesity. More research is being done on that, and later development of glucose intolerance and diabetes, which we are seeing. Breastfeeding women with overt diabetes successfully using metformin or glyburide should continue these meds even through breastfeeding. So we don't want to stop it with overt, but you will with gestational. Metformin does cross over, it's just very low, and glyburide is okay, it does not. Try not to read this all to you. So progestin-only oral contraceptives do not affect plasma blood glucose in women with type 1. However, there's some limited evidence on these meds increasing later with type 2 diabetes in women who have gestational diabetes. So you don't want to not do it, but know that it's a risk factor. The choice of contraceptives should not be influenced by having overt diabetes or a history of it. So we know it's possible, but we just need to utilize whatever is good of patient's preference. Combination oral contraceptives, patch, vaginal rings, and IUDs can all be used postpartum and not worry about sugars. Next slide. Postpartum thyroiditis. Don't see it as often with type 2, but you certainly can. We have a lot of referrals that come here for the TSHs being a little bit high or off in the first 3 to 6 months. So we see it with type 1 diabetes, and we actually screen for it, but it's not also uncommon. Actually, we see some of it in type 2s as well. Remembering thyroiditis should resolve on their own. So if they don't, then you might want them to seek care with us. But thyroiditis isn't something that we treat, but sometimes patients are symptomatic with feeling a little bit anxious or a little bit heart rate, maybe a little bit shaky. But let them know that it should resolve postpartum. That's all we have.
Awesome. That was wonderful. Thank you. All right, guys. Time for questions. All of you are on mute, so make sure you unmute yourselves. All right. Well, if there are any questions afterward, I'll be sure to pass it on to you guys. Thank you so much. That was great.
All right. Thank you.
Yeah, thank you. Our next session is going to be July 10th. All right, everybody, I'll make sure to send out that reminder. Thank you all again.
Thank you.
Bye.